his science. Really, we do appreciate, and we will remember him forever. Thank you for being with us today.
Thank you, Erica. And now I'm gonna introduce you to Daniel. Daniel is the president of the International Council of Respiratory Care. He works as a respiratory therapy clinical coordinator at the University of Virginia, adult critical care specialist, neonatal pediatric respiratory care specialist. He has many international publications in peer-reviewed journal, member of the American Association of Respiratory Care, and a national board for respiratory care. Hello, Daniel. Welcome here.
Thank you for the introduction, and it's a pleasure to be part of this symposium that you've put together with a lineup of outstanding presenters that are internationally renowned. And I commend the work that the program committee has put into offering this to the attendees. Thank you for having me too.
Thank you. I guess you are going to introduce John, so our first speaker.
Yeah, so it's a pleasure for me to introduce the first presenter. It's John Gallagher, who is a registered respiratory therapist and education coordinator of critical care at University of Hospital at Rainbow Children's Hospital in Cleveland. He's a clinical expert and administrative professional in respiratory care with extensive tertiary care experience. He's an accomplished scholar with advanced education and a skilled author and researcher. And he's going to be presenting on the topic of delivery room ventilation. So without further ado, John, are you on?
I am. Thank you, Dan.
Could you share your presentation with us, please?
I sure will. How does that look? Can you all see?
Yeah, clear.
Okay, great. Well, thank you for the introduction and the invitation to participate today. It's a pleasure to be with all of you. I want to add that I had the privilege of serving as the liaison from the American Association for Respiratory Care to the Neonatal Resuscitation Program by the AAP in the United States. I participated on that program for 10 years, and that concluded about 1 year ago. So the topic of ventilation of the newborn in the delivery room is a topic that's near and dear to me, as it may be to many of you who all work in this field of both neonatal care, whether it's in the NICU or in the delivery room. So what I'd like to offer today is an overview of ventilation of the newborn in the delivery room. And I look forward to presenting this information and any topics of discussion we might have at the end. So let's get started. One of the main tenets of NRP, which is highlighted in each edition year after year, is the tenet that the ventilation of the newborn's lungs is the single most important and most effective step in neonatal resuscitation. And for those of you who have participated in neonatal resuscitation, you're quite familiar with this concept that if we are unable to actually provide effective ventilation, we're not going to see an increase in heart rate for the depressed child. So all the effort and focus during a resuscitation really centers around ventilation, centers around the concept of effective ventilation, which incidentally is a term that's hotly debated. What exactly does effective ventilation mean? But nonetheless, we focus on the movement of the chest and gas exchange to facilitate the early success of our resuscitation. Today we'll examine briefly some fetal gas exchange and introduce the concept of umbilical cord clamping and what roles that might play in ventilation, both in the moments of delivery and the moments following delivery. We'll look at some of the main components of the NRP guidelines on ventilation. We'll discuss the methodology, what we use, how we use it, what parameters we use, and we'll wrap up with some other interventions that are sort of hot on the press today, and what might be our approach kind of going forward in the years to come. So taking a quick look and considering what life is like in utero, important to remember that we are in the process of fetal lung development, and with that we are relying on fetal lung fluid as one of the major components of that development. Fetal lung fluid, of course, full of electrolytes and proteins, is going to play that crucial role in the development of the lungs. And that fetal lung fluid actually provides that distended state of the alveoli, that exact distended state that we're going to try to achieve once again, once that fluid is removed. So therein sort of lies the challenge. We have distended alveoli. We just need to remove the fluid and re-distend those alveoli. So that's kind of really our challenge. Postnatal lung fluid reabsorption is mediated through activation of airway epithelial sodium channels. Typically in utero, it's happening through chloride channels, but the sodium channels become activated in the first moments of extrauterine life. Interestingly, there are fetal breathing movements. So despite the fact that the child is receiving gas exchange through the placenta and the umbilical cord, there are fetal breathing movements, which is actually, you can almost think of it as we're fine-tuning the breathing apparatus in preparation for extrauterine life. So there's a centrally organized rhythmic contractions of the diaphragm, not necessarily in the same rate or rhythm that we might see in extrauterine life, but it's almost just like a workout that sort of comes and goes as the child progresses in gestation. That does sort of activate those chest wall muscles and sort of facilitate the upper respiratory tract in preparation for birth. Transitioning, however, from that fetal world into becoming a neonate is a complicated few minutes, and we're all certainly aware of that if we've gone to some deliveries. There's a lot happening, and the full amount of details aren't exactly known, quite honestly. But here's kind of what we do know. So we begin with fetal lung fluid filling the alveoli, and whether we are born through a vaginal delivery or cesarean delivery also may play a role in how well that fetal lung fluid is expectorated and sort of coughed out, if you will. We tend to find, even anecdotally, if nothing else, that children born cesarean section tend to retain a little bit more of that fetal lung fluid and need a little extra support in the first moments trying to remove that fluid. During placental attachment, gas exchange occurs through the placenta and the umbilical cord, and we maintain very high pulmonary vascular resistance. So when we look at this first diagram here, and we see the lungs here with the right heart and left heart, that high pulmonary vascular resistance is preventing all of our right heart blood, basically, from going into the lungs via the pulmonary artery. And it's diverted through shunts like the foraminal valley and the ductus arteriosus. And ultimately that blood, as you see, kind of skips the lungs completely and then makes its way to systemic circulation. It's at delivery, and it's at cord clamping here of placenta to child here, where we start to begin and have diversion of blood flow. With high pulmonary vascular resistance still maintained, blood flow will continue through the foraminal valley until that begins to close, but largely will follow the path of the ductus arteriosus in the first moments of life and simply bypass the lungs until lung aeration basically takes place. Once we're actually able to recruit that lung with air, we then are able to decrease that pulmonary vascular resistance, as we're seeing here in this third diagram, decreasing that pulmonary vascular resistance, sending that right heart blood instead of through the shunts, but now through a normal pathway of heading to the lungs and then back to the heart for circulation to the systemic vasculature. So it's a complicated sort of set of plumbing arrangements that have to occur and have to occur rapidly. Some of the questions, however, as you see as we'll go, will revolve around the timing of this clamping and whether or not any support should be provided to the lungs prior to clamping. So we'll evaluate that a bit as we go, and perhaps we can discuss that in your practice at your facilities at the end when we do have a few minutes for discussion. Umbilical cord clamping, again, what we just mentioned, timing is variable by situation and location. Some institutions have adopted a delayed cord clamping procedure for certain patients. Others maybe have not. But classically, we've been early cord clampers, and now the trend is into delay that cord clamping, but we'll touch on that in a second. Ultimately, as we've just said, what we're aiming for is a decrease in pulmonary vascular resistance. And with that, we get pulmonary blood flow. And finally, we get fetal shunt closure. So if we can get through this mechanism in the first moments of life, then we're on a good pathway to successful transition. However, that is often cut short through complications. So we began discussing cord clamping already. Let's just kind of remember, in uncomplicated term or late preterm birth, it may be reasonable to defer that cord clamping time until after the infant is placed on the mother and assessed for breathing and activity. So fully acceptable, and I think perhaps even culturally variance throughout the world on the practice of leaving that cord intact, attached to the placenta, even having placental delivery, and then clamping. However, we can sort of designate and delineate rather the two categories of early cord clamping being within the first 30 seconds of extrauterine life, but doing so may interfere with healthy transition. It leaves fetal blood in the placenta rather than in the newborn's circulating volume. There are tendencies and other practices involved surrounding early cord clamping. In fact, there was a trend in which there was cord milking, and we would, you'd have a delivered child still connected to the placenta, and before the clamp, the OB or neonatologist would sort of literally milk the cord and push the blood volume towards the infant. That is suggested against, especially in the preterm children. There was evidence of intraventricular hemorrhage associated with that flushing and pushing the blood volume. So we're away from that tendency. What we are aiming towards is the second category of delayed cord clamping, which by definition is going to be longer than 30 seconds. There are groups that aim to do it for 60 seconds, perhaps even 90 seconds. The data isn't strong yet on what is that optimal time. Our center in Cleveland, we use 60 seconds for those who meet the good criteria for this process. But when that's done, there is an association with higher hematocrits for those children and iron levels. This may aid in motor and cognitive development. For the preterms, it reduces the need for pressors and potential transfusions upon arrival to the NICU. So it seems like all the arrows point to delayed cord clamping as being advantageous. The question is, what do we do for the child who is showing signs of respiratory distress while you're waiting to clamp that cord? Well, for now, there is insufficient evidence to recommend delayed cord clamping if the infant is requiring PPV. So what does that mean in the long term? It's really hard to say, but I think clinician and clinical judgment will rule. If your child is severely depressed and not making spontaneous breathing efforts, the length of the delayed cord clamping should be or could be cut short until more knowledge is gained on the topic. Keeping in mind fetal lung development and remembering, so now let's say we've delayed the cord clamping, our 60 seconds per se, we clamp, we cut, and now we're expecting this child to absorb fetal lung fluid, expectorate the rest, and begin ventilation on their own. Well, I included this chart just to remind us all that as we look around this continuum of premature gestation and birth, that our fetal lung development is nowhere near ready for what we're actually designed and prepared to do in the full-term and postnatal stages. Our preterm children who are born with significant underdevelopment and inadequate physiology from a parenchymal standpoint and from the mesenchyme of that VQ matching. So we have an inherent challenge, of course, of ventilating children here in this range, in this saccular stage of fetal lung development, as we are trying to begin that resuscitation and get those air sacs or air channels, if you will, tubules filled with air. Again, if we acknowledge the surfactant issue as well, where surfactant production is going to peak here at full term, but there will be some surfactant production here in the preterm kids. How much? It's a little dependent upon the kid and some prenatal care and some obstetric care, of course. But that's another challenge that we're facing. We're facing a lack of surfactant along with lung immaturity and poor physiology. So here we're reviewing the most recent updates. This is currently the 2015 edition of Neonatal Resuscitation Program. The algorithm for the 2021 edition, which is publications from 2020, will be released this summer, and I believe it's May or June. But I'm told that there are no changes to the algorithm, so the algorithm itself will stay intact. There are some other components that will change, however, but we can still focus and trust this algorithm that will be in use for the next 5 years, at least in the United States, and for all other editions of NRP that get translated or adapted into different nations. This is our algorithm. So, as we mentioned at the beginning, the primary goal of neonatal care at birth is to facilitate that transition. Most important priority is adequate lung inflation and ventilation to maintain survival. So you'll recall, if you're familiar with the algorithm, that evaluations are made along the care path as we go. And really the main evaluation here, as you see in this stage and in this stage, here again and here again, is heart rate. And is the heart rate increasing? Well, it's really the adequacy of ventilation that is going to increase the heart rate. So we have no time to waste. And in fact, NRP highlights that in this first minute of life, our aim is to achieve adequate ventilation and get that heart rate above 100 beats per minute. Important to note that early ventilation is key because the risk of death increases 16% for every 30-second delay in initiating ventilatory support in the newly born infant. So there is, as I said, no time to waste. So we'll continue talking about those types of things. The challenge, of course, is establishing that adequate ventilation. And as you see here in this third bullet point, improper positioning is one of the most common reasons for ineffective masked ventilation during NRP. So special care is taken to find appropriate head positioning and to establish an open airway. That open airway here, as we can kind of see in this sort of simulation, this open airway is going to facilitate both fetal lung fluid removal in their spontaneous coughing, as well as adequate airflow and relief of any sort of obstruction from the cricoid cartilage and ring there. So head and neck in a slightly neutral, slightly extended position, and we may benefit from a shoulder roll in those moments. PPV, positive pressure ventilation, is the primary method for providing support to these newborns, whether they're apneic, bradycardic, or having inadequate respiratory effort. All the data suggests that these babies, and the data is old, as you see here by this 1996 study, babies will respond to PPV, and we rely on animal studies early on that looked at newborn mammals that were asphyxiated, and as those asphyxiated animals were ventilated, we saw rapid increases in heart rate. So that became the very basis of NRP and how we focus on ventilation as being the key determinant of success in the newborn in the delivery room. The ventilation rate, as we're all instructed to use, the guidance is 40 to 60 inflations per minute. That is not based off of any sort of controlled trial, but rather expert opinion as the data on that exact number is limited. When ventilation is not increasing the heart rate and the chest is not moving, we rely on ventilation corrective steps. The ventilation corrective steps, as outlined in NRP, really follow this mnemonic of Mr. SOPA. For the ladies in the room, we acknowledge it as Mrs. OPA, but I'm not sure why we assigned it Mr. SOPA. But nonetheless, we are focusing on mask adjustment, repositioning the head, suctioning the airway, opening the mouth, increasing the pressure on your resuscitation device, and ultimately choosing an alternative airway. So if your heart rate is not responding, you have to run through this sequence of corrective steps. And ultimately, if the sequence of corrective steps does not provide you with effective ventilation, then you have to choose your alternate airway, which first off would likely be an endotracheal tube. Here's just a reminder of the guidance for the endotracheal tubes. We typically are going to use 3 sizes of ET tubes, the 2.5, the 3.0, and the 3.5 millimeter tubes. Of course, the kids, even when we do our training here, we never weigh a kid in the midst of a resuscitation. So it's also important to know good gestational age breakdown. And if we just kind of keep these cut points in mind, the 28 and the 34 mark, less than 28, use that 2.5. Greater than 34, use the biggest, the 3.5. And in between, use that 3.0. For placement, NRP provides a very detailed list based on clinical data and research done on this topic. And these are very specific and pointed recommendations. There are other more easy to remember recommendations, but this is the most accurate, and this is what's used by NRP today. Devices for PPV. So when we are trying to establish that ventilation, we have several choices, of course, 2 of which are here and illustrated. The third, the flow inflating bag, I chose to omit for this discussion. But the T-piece resuscitator, there's evidence of T-piece resuscitation being used as far as 100 years ago in the United States. It made a resurgence in the past 25 years and is a commonly used device to facilitate newborn resuscitation. It directs compressed gas towards the baby when the opening on the top of the T-shaped device is occluded. And of course, we have the self-inflating bag that can be used with supplemental oxygen and delivers positive pressure ventilation when squeezed and released. 3 randomized control trials compared the 2 devices, the T-piece using PEEP and the self-inflating bag without PEEP, and each of those studies reported similar rates of death and chronic lung disease, showing us that there was really no superior device, at least from that evaluation. So NRP has not suggested one device over the other at this point. What pressures do we use is a common question. The pressures required to move the chest, I think, is a good short answer. Typically, NRP suggests that we start at 20 centimeters of water pressure for all kids. That pressure, again, I think is largely based on expert opinion, but we do have several smaller studies that have looked at ventilating pressures, and we have found that term newborns resuscitated using peak pressures of 30 centimeters of water did well, and preterm children also did well at 20 to 25 centimeters of water pressure. Again, from a very clinical perspective, the pressures required to inflate and adequately ventilate a newborn may differ with mask ventilation to endotracheal tube ventilation. So typically you'll find with mask ventilation, we have a lot more soft tissue that we're encountering that has to be overcome with pressure. So oftentimes we use more pressure, at least in our clinical practice, we use more pressure with mask ventilation. But once the endotracheal tube has been placed, we can lower that pressure because the airway resistance has been decreased. So important to kind of keep in mind as you're trying to ventilate your children. For PEEP measurements and for PEEP usage, PEEP, of course, is going to provide some inflation to the lungs during exhalation. It's been shown to maintain lung volume during PPV in animal studies, improving lung function and oxygenation. It may be beneficial, but as it stands, evidence from human studies is limited. As much of NRP, you will find limited human data, largely due to challenges with enrollment into these studies, of course. An observational study you see down below, PEEP saves lives. This observational study from 2018 included nearly 2,000 infants that were all preterm. And with those children, there were reported lower rates of mortality and chronic lung disease when delivering ventilation with PEEP versus without. And several studies supporting the benefits of using PEEP, including lung aeration, which we discussed, establishment of FRC, decreasing resistance, increasing compliance, conserving surfactant, preventing alveolar collapse, inhibiting the expression of pro-inflammatory mediators. So lots of benefits of PEEP, and as it stands, it is suggested and it is encouraged in newborn resuscitation. Tidal volumes is a hot topic. We don't really have great methods of measuring tidal volume in the delivery room, unfortunately. And I think the thought leaders on this topic are really, really eager to get some sort of tidal volume measurement during newborn resuscitation. As it stands, we don't really have anything. Peak inflation pressures and tidal volumes greater than what's required to increase the heart rate and achieve chest expansion should be avoided. Just good wisdom there. If your chest is rising nicely, of course, no need to use more pressure simply due to a DSAT, but instead just maintain normal chest excursion and try not to overexpand. You see in 2019, there was an observational study of newly born infants associated with high tidal volumes during resuscitation and brain injury. They used several levels of tidal volumes, like 8, 12, 15, 20. And in all these studies, when we see tidal volumes of like 15 mLs per kilo, 20 mLs per kilo, that's when we start to see these really ill effects. Over on the right, you see several animal studies found that ventilation with high volumes caused lung injury, impaired gas exchange, and reduced compliance in these immature animals. So in those studies, they used things like 5 ml per kilo tidal volumes, then 10 ml per kilo tidal volumes, and 15 ml per kilo tidal volumes. And it was in those 15 ml per kilo tidal volumes where we saw all these ill effects. So at least what we have to go by so far is that we need to steer away from tidal volumes that are greater than 10 per kilo. At least that's what we have right now. Unfortunately, we don't have a great way to measure that in most deliveries. Inspiratory time and sustained inflations. So if you look here at this photograph of the T-piece resuscitator being actuated, now we've got an occlusion over that T-piece. That occlusion over the T-piece really is our inspiratory time. And with the untrained hand, that can be excessively held. And if you hold it for longer than 1 second, you're basically into a sustained inflation. And if you look over to the right, we've got systematic reviews in preterm kids that say that kids using sustained inflations don't do well. One review found a higher risk of death in the first 48 hours, and another one was stopped early because mortality was identified. So sustained inflations really, were once kind of a prospective and popular idea. Right now, the suggestion is not to do it. So keeping our inspiratory times less than 1 second is key, and noting that an inspiratory time of these children is typically at 0.2, 0.3 seconds. So being somewhere around the 0.5 second mark is a good spot to be for our eye time. Oxygen management, again, not much has changed in the last 5 to 6 years regarding the data surrounding O2 management. What we do know is that term and late preterm newborns do well on 21% versus 100%. There was no difference found in neurodevelopmental outcome of kids in either case. So, of course, we erred on the side of caution with 21. So key reminders that during resuscitation, pulse oximetry should be used to monitor saturation levels and to guide our O2 management. In the more preterm kids, there were no difference in mortality or other important outcomes when respiratory support was started with low FiO2s versus high. Given the potential for harm for hyperoxia, it's reasonable to start with somewhere around 30% oxygen for the preterm kids. So that's where NRP guides us. We go to 30% for the preterms and 21% for the full terms. Guiding our pulse oximetry is really, the data from our pulse oximetry is really what guides our O2 management as the resuscitation continues. The data that we're really following here in NRP is allowing for normal transition of fetal shunt closures and for extrauterine life to sort of transition. So what you see here are data taken from children who were full term. We don't have any preterm data here, but these are full term children who did not require resuscitation, but they just were monitored for their normal saturation. And this is the curve that we have seen, that it takes at least 5 minutes to reach about 90%. And it's not until 10 plus minutes do you reach the mid 90s. So having realistic goals in the early minutes of resuscitation are completely appropriate. Again, we don't have preterm data on this, but at least we know what a term baby sort of typically does. The newest, and I'll begin to wrap up now, but the newest sort of approach is an old approach, but it's new again. And we're really aiming at providing CPAP in the delivery room. We've got multiple randomized control trials, a meta-analysis showing reduction of death and BPD when we start CPAP early. The meta-analysis reported no differences in outcomes of mortality, BPD, pneumo, IVH, NEC, or ROP. And so the real push now is, especially for our preterms, is to start with CPAP in the DR. CPAP can be applied with a T-piece resuscitator or a flow inflating bag, but cannot be done with a self-inflating bag, important to note. Also, we, at our institution at least, we are using a generated, a CPAP generator and a headgear at the delivery room just to establish CPAP and to sustain it at reliable levels for our preterm kids. And lastly, what does the future hold? Well, there's an exciting study that is underway. They completed a feasibility and safety pilot, basically looking at during cord clamping, and the question came up earlier. Remember, during cord clamping, we see signs of respiratory distress. Well, we want to know, can we get the benefits of both sort of approaches? Can we apply positive pressure ventilation or facial CPAP while maintaining delayed cord clamping? So this multi-center study called Vent First looks to do that. And in their pilot feasibility and safety, they did find that everyone that they treated in this method, which I believe was only about 29 infants, all did very well, and all did, it was very safe. So what we're looking at next is potentially doing this with preterm kids, which now really starts to shake up our model. We're going to maybe consider as we go forward in the future, thinking, what are we going to do in the delivery room? Are we, we could have a child who's still attached to the placenta via the umbilical cord, and we're there as clinicians providing PPV or facial CPAP while that cord is still maintained. So in summary, let's be prepared. Let's know what to expect in these deliveries. Ventilate early, don't delay. Remember that ventilation is the key to success in resuscitation. Use any device that you want, just use it well. Use safe pressures. Be mindful of volumes. That big volumes are certainly going to be bad. Be conservative with your oxygen and use pulse oximetry to guide as you go through your delivery. And don't forget, early CPAP works. So I really appreciate this invitation and this opportunity to talk to you, and I welcome any questions you might have right now.
Thank you, John, for such an illustrative talk. We'll take the advantage of you being here with us. But first, Erica, she's in a hurry. She joined us so to meet all of you, dear colleagues. Hello, Erica. Hi.
Hello, everyone.
Hi,
Hello,
dear.
Erica.
Hi. Thanks for having me.
It's nice to be able to join us. Professor Sham, our professor, is actually want to say something to you.
Sure.
Erica, we are pleased to have you with us today. Your presence remind us with great Craig, who had the kindness to come to Egypt 2017 when the rest of the colleague refused to come to Egypt. He shared with us his knowledge and he participated in our third meeting, and his participation was extremely fruitful and helped us a lot. We cannot forget his kindness and his eagerness to share with us his all what he knows and to help to benefit the junior staff. Really, we were pleased to have him with us, and we are pleased to have you with us and to give you our sincere condolences.
Thank you so much. Thanks for inviting me, Dr. Ranya. I'm honored to be here. I know Craig was so happy and honored to be a part of your conference 4 years ago. I was actually very disappointed that I couldn't go. So hopefully one day we can meet face to face. Thank you for taking care of Craig when he was with you. That meant a lot to me. And thank you all for your continued work and research in neonatal care. I know Craig was very proud to be a part of this community. He had this in his office, so I keep it with me. So sorry. But my kids, Sadie and Max, they're growing. Sadie is 6 and Max is, he'll be 2.5 next month. So when you think of us all together. We obviously miss Craig dearly, and I know he's missed by this community, but thank you for continuing his work, and I'm just very grateful to be here. Thank you.
Erica, when we had only one day chance to go around the old city after the conference, and we went to the Egyptian Museum and the pyramids, and he told me that next time you will be there, and the kids will be happy to meet you here one day.
Yes, I will. You will be the first to know, Dr. Ranya.
Thank you. Thank you.
Thank you. Thank you very much.
Thank you. Bye.
Thank you.
Bye-bye.
Actually, we're late, but I'll take the advantage of you being here without John to leak us a hint about the 2021 NRP updates. Is there any change you can tell us about?
I'm sorry, I lost my screen. So I did participate in a brief webinar recently, and there are very limited changes to the science, I think, thankfully, because we've but we had to endure several editions of frequent changes in science. But really what's the main change from NRP this go around is their rollout and how they are going to, they've categorized now 2 different categories, basically a basic level and to an elite level, or pardon me, a superior level. I forget the terminology, but they've subdivided the program into 2 categories. And for some staff, it may be beneficial to just focus on some ventilation key parts versus the whole program. So that is one of the changes. Also, how they are going to do testing. They're going to embrace the RQI methodology that BLS has done in the past, which is episodic learning, basically, and it's like every 90 days touching base at a device and reviewing skills. So they're going to be embracing RQI as well. So those are the big changes coming at NRP. But again, the science is staying intact for now.
Yes. Dr. Rashid? Yes.
Thank you, Dr. John, for your talk, fascinating talk. I want to ask you 2 questions. The first one regarding the nasal ventilation during resuscitation, the delivery room, to use nasal plunge rather than the facial mask to avoid the dead space of the mouth and to avoid all the problems associated with this dead space and ineffective ventilation. The other question, do you think in the near future we'll have a tool to assess the tidal volume during resuscitation? Because in the Sydney, in the work done in Sydney, the tidal volume during resuscitation varied from 0 to 35 cc's per kilo. This is tremendous, and it were associated with bad neurological outcomes simply after the delivery room resuscitation. Do you think, do you have in mind, or do you see any solution for this unestimated tidal volume delivery during resuscitation?
Thank you for the great questions. Both are very pertinent. And I think the first question regarding nasal prongs, it depends, I think, to some degree if the specific device that you're talking about, and if you're referring to a device similar to something called the RAM cannula, which became popular in the United States. I'm not sure about Egypt, but a device like that is not intended to create a seal within the nares. And when it's not intended to create a seal, it's very difficult to establish effective ventilation with that gross amount of leak. So in those cases, the nasal prongs were less advantageous, at least in small bench studies, and anecdotally, they were less effective than a mask seal. And if you're talking specifically about mask CPAP, there are interfaces, of course, as you're aware, that are prong-based interfaces for facial CPAP. The question just becomes when you want to now turn it into PPV. Sometimes those interfaces are connected to a generator that are not capable of providing PPV. So you do have the advantage of prongs for CPAP, but I don't think that there is a very good viable option yet for prongs for PPV, unfortunately. For tidal volume measurement, I know even from my experience on the steering committee, there were several individuals and young investigators who were applying for grants through the NRP program at the AAP who had novel approaches to measuring tidal volume. None of them were widely reproducible, unfortunately, and that made it limited in our ability to sort of advocate or to promote a certain application for tidal volume delivery, unfortunately. But I do believe that there are devices out there that can give us some real-time tidal volume data, but I think we're inhibited by cost. We're inhibited, it's hard enough to get blenders at bedsides for delivery, let alone a tidal volume measurement device. But I think the real challenge is, can we find something that's affordable, that's transferable, that's reusable, those types of things that we can use, and I think that would be a game changer. But for now, I think we're limited by the technology and the cost of the technology.
Thank you.
Sure.
Okay,
thank you for the questions.
I guess, thank you, John. I guess
Dr.
Robert didn't be able to join us till now. So Dr. Hisham, would you present Dr. Lisa?
Dr. Lisa, thank you for being with us. Dr. Lisa